patients with isolated RBD, they show brain atrophy, but they also show changes in brain perfusion and metabolism. So the brain uses glucose as its main energy fuel. And we know that the brain in these patients does not consume glucose the same way. And there are many studies showing that, well, there seem to be some covariance patterns, peculiar to isolated RBD, and that these predict pheno-conversion, so conversion to Parkinson's disease, conversion to dementia with Lewy bodies. But so far, the problem, or at least the limitation of these studies, is that they do not allow us to predict who's going to convert to Parkinson's disease and who's going to convert to dementia with Lewy bodies. And this is important because when you see a patient with isolated RBD and you know they're going to develop Parkinson's disease or dementia, you probably want to know years before in advance whether someone is going to have dementia or not, because this changes everything. It changes patient care, it changes what kind of medication you want to give them, and et cetera. So we need a pattern, an imaging marker that is able to predict who's going to convert to dementia and who's going to convert to Parkinson's disease. And so far, the marker we have in terms of perfusion can only predict who's going to convert in general, so the rate of progression, but not the differential progression. So I wanted to have a solution for this. So we recruited 74 RBD patients and 30 control subjects. So they underwent neurological evaluation, neuropsychological evaluation, just to be sure that they still didn't have Parkinson's disease. They still didn't have dementia with Lewy bodies. They underwent polysomnography to be sure that they had RBD. They underwent also a SPECT scan. So we injected a ligand, HMPAO, to measure the perfusion of the brain in every brain region. And then we used a technique called partial least squares correlation, Pls correlation. What it does is, so far in the studies, they've looked at the brain, they measured the changes, and they use these changes in the brain to predict who's going to convert to what. And it didn't work out well. What we did here with Pls correlation is, instead of just looking at the brain, we looked at the brain and clinical features, both of them at the same time. So with Pls correlation, what we can do is we take two matrices, one matrix of perfusion and the whole brain, and a matrix of clinical features. And we derive components that maximize the covariance between the two matrices at the same time. So we get components that summarize the information in both brain perfusion and clinical features at the same time. And then we check whether these components are significant statistically or not. And what is super interesting with this is that every component can be described in two terms, a brain pattern and a clinical pattern. And the brain pattern can be projected back onto the patient scan to derive a single score representing the expression of the pattern in these patients. So you get to get one component with a brain pattern and a clinical pattern. And so this is what we did. So we used the perfusion scans of the patients. We processed them using SPM12, and then we took 27 clinical features, which covered clinical features that we know are affected in isolated RBD patients, motor features, cognitive features, olfaction, color vision, age, sex, etc. So we had one perfusion matrix, one clinical matrix, and we derived components that maximized the information between the two. And doing this, we identified 27 components, and then we assessed statistical significance of these components, and two of them were significant. So the first one was characterized by sub-cortical hyper-perfusion and cortical hypo-perfusion. So increased perfusion in subcortical structures and decreased perfusion in cortical, especially posterior regions. And this is what we know from RBD. We know that this is the kind of pattern that we expect in these patients. And when we look at the clinical features associated with this, they were motor functions, cognitive functions, olfaction, age. So, mostly motor and cognitive functions. So it made sense. So it's a covariance pattern that really maximizes hyper-perfusion, hypo-perfusion, and clinical features in these patients. And then we projected back the pattern onto every patient scan. We derived a score, and we used this score to see, well, can it predict dementia versus Parkinson? This is what we wanted. And it predicted pheno-conversion, but it did not predict who's going to convert to Parkinson's and who's going to convert to dementia, unfortunately. However, the other component, because there was another component that was significant, the second component, it was characterized by increased perfusion in the bilateral insula, the medial frontal cortex, spreading to the basal forebrain. So the basal forebrain is a region that is super rich in terms of acetylcholine. And this is super important for cognitive functions, and it's depleted in dementing syndromes. So it's super interesting. And the clinical features that were associated with this pattern were the presence of mild cognitive impairment, visual spatial functioning, color vision, which is a very cognitive test. And when we derived the score for this pattern specifically, we found that it did predict dementia with Lewy bodies over Parkinson's disease. So the more this specific pattern of hyper-perfusion in the insula and the medial frontal cortex, the more it was expressed in the patient, the more likely the patient was to convert to dementia versus Parkinson's disease. So in this study, in summary, this is what we show. We show that there exists a pattern that is able to predict dementia with Lewy bodies in comparison to Parkinson's disease. And this kind of represents one of the first markers able to predict one phenotype versus the other in these patients.